Welcome to today's session of the Health and Social Care Select Committee on the inquiry of adult social care reform, the cost of inaction. For the record, may I ask our witnesses today to introduce themselves and what they do, starting with Anita Charlesworth.
Hello, I'm Anita Charlesworth. I'm a health economist. I work for the Health Foundation. Also relevant, I'm the Vice Chair of North West London Integrated Care System, and I should declare that I've recently become a trustee of Health Service Research Data UK.
Thank you. And you're also a member of our independent expert panel.
I am indeed.
Thank you. Oonagh Smyth.
I am Oonagh Smyth. I'm the Chief Executive of Skills for Care, and Skills for Care is the workforce development and planning body for adult social care in England.
Very much. And Emily Holzhausen.
Thank you. I'm Emily Holzhausen. I'm Director of Policy and Public Affairs at Carers UK, so representing families who provide unpaid care. I'm also one of the 3 co-chairs of the Carers Support Alliance, an alliance of 60 organisations who are campaigning for better social care.
Thank you very much, all 3 of you, for appearing in front of the committee today as we try and unpick all the numbers around health and social care and its contribution to our country. Oonagh, may I start with you, and particularly the Skills for Care research that's been commissioned that found that adult social care contributes £68.1 billion to the economy. First of all, could you just explain briefly how was that figure arrived at?
We know that adult social care is fundamental to the people it supports, community infrastructure, but also the economy. The report that we published and the figures that we published say that, as you say, adult social care adds 68.1 billion to the English economy every year, and that is made up of 3 things really. One is the direct effects, the direct contributions, which is really salary and profits, and that's about just over 31 billion, and then just over 15 billion to the indirect contributions, so that's really supply chain impacts, and then the third element is induced contributions, which is about 22
billion. Do you mean by that?
So that's essentially money spent by people working in adult social care, and those 3 things combined make up the 68.1 billion. Adult social care has a huge workforce, so almost 1.6 million people working in adult social care. So it's more than 5% of all jobs in England are in adult social care. So just a really significant sector.
Okay. But do you feel that there is space for that contribution to grow given specific reforms, and have you done any work around that?
So we haven't done any specific work on what that would look like if it did grow, but bearing in mind that it grew about 13% in 23-24, we can expect it to grow when we look out to the future. Just looking at demographic changes alone, the number of people working in social care, we project if the number of people working in social care were to grow in proportion to the changing population, we would need an extra 540,000 posts by 2040. Mm-hmm. And so the economic contribution will really grow if we pay people more in social care, and obviously we've had the commitment around the Fair Pay Agreement, and so if that's implemented and funded, then we will expect to see that economic contribution growing. So paying people more and also employing more people. So those are the 2 real factors that will have an impact on the economic impact of adult social care.
And of the things that you predict that might help it to grow, are there any that would help to grow sort of the new money aspect of it? Because if it's Treasury primarily funding much of this stuff, they would see this as a sort of recycling of the money they've already got. How would you encourage the government to look at adult social care as a industry that grows, but that money could also come from other sources? Would you characterise it that way?
That's possibly a question more for Anita than a workforce-specific question, I think.
Okay, fair enough. Anita, do you have a...
Yeah, so I've thought about this question about the cost of inaction on social care from a government economic growth agenda and how social care contributes to economic growth, and therefore how reform hinders, lack of reform hinders economic growth. And what to think about starting out that Andy Haldane, the former chief economist of the Bank of England, gave a lecture 2 years ago where he talked about the contribution of health to economic growth. And he talks about there being two cylinders in the engine for economic growth. So one is the number of people who are able to work and the hours that they can work in economic speak labour supply. And the second thing is the productivity of those workers. And you can think about the problems in the social care sector affecting both of those. So obviously in the labour supply, there are two key groups, I think, where failure to provide appropriate social care, failure to provide that in ways that meet people's needs, affect labour supply. So one is there are increasing numbers, actually, of younger working age adults who are using social care. When we talk about social care, we tend to focus on adults, but half the budget and about a third of the recipients are younger adults. Many of those will not be able to work, but some of those with appropriate support could work, and the Care Act explicitly tried to have a much wider sense of what effective social care would be, which recognised wider contribution. And I think progress to actually realise that vision has been low. So that's one group. The second group are carers who are caring such large number of hours that it is affecting their ability to work. And 4 in 10 working age carers report that lack of support means that they are working fewer hours than they would want to. Yeah. So if you like, that's one of Andy Haldane's cylinders, where you can see not providing appropriate social care potentially affects our economic growth. The second area is around the productivity. And I'd like, if I may, just to talk about this in relation to a paper that Rachel Reeves wrote back in 2018, when she talked about the importance of the everyday economy. So if we think about, the challenge of raising productivity, raising economic growth across our economy, which is absolutely fundamental, we need, obviously, to ensure that we are able to really develop the sectors in which we excel, which are high value added. So advanced manufacturing, what they call the strategic sectors in services, life sciences, financial services, business services, all those things. High paid, high qualification, traded. But as Rachel Reeves points out, you can't have an economy where everything is either advanced manufacturing or those high traded. What also really matters in our economy is what she calls the everyday economy. Those are the goods and services, particularly services, that we all need and use for life. And they tend to be low paid, low productivity. And social care is one of the biggest sectors within that everyday economy. And what really matters there is that in the everyday economy, those sectors are as productive as they can be. Mm-hmm. Yeah. And we have seen in social care, according to the ONS data, that since the late sort of about 2008, productivity in the social care sector has not really increased. Now, there are challenges in measuring it, and actually it might. I think probably, the adjustment for need and complexity is not where it would be, but it hasn't increased. And I think they would probably point to 3 things which have hindered the productivity of the social care sector and seem to me to be one of the ways in which lack of reform really affects economic performance. One is our approach to the labour market and the reliance on a high turnover, low-skilled workforce with very low differentials, which mean that there are no real incentives to train and develop your skills. And where you do, we see then that people can move into the NHS, which is good for them, good for the NHS, but not good for the social care sector. The second thing is undercapitalisation in the sector and very expensive capital. And I know you've had evidence from HC1 who make this point. Because of the way we commission social care, lots of spot purchasing, lots of uncertainty. Social care providers are paying a very high cost of capital. That is money which could be going into improving the sector, which is going into hedge funds. Yeah? Same problem in children's social care. They argue, and I think this is something that I would hope Louise Casey's review will really focus on, that potentially if we commissioned in a different way, we could create opportunities there for the sector to have a lower cost of capital, which would really benefit its ability, without extra treasury money, to improve. And that access to capital really matters, obviously, because one of the huge issues in the social care sector is it's almost certainly under-digitised, yeah? And so it is not being able to take advantage of technological innovation. And then the way we commission social care also is very much a commissioning model which I think drives out innovation. You know, we commission tasks which are both incredibly reductionist as human beings, but also actually make it incredibly difficult for people in the social care sector to innovate and provide care in different ways. And so there are some really impressive innovations, but it is despite the system, not because of the system. So we need social care, because it will grow as a sector, to be able to be as productive as possible. That doesn't mean flogging the workforce ever harder, actually, which is what you do when you can't be productive, actually. Almost that is the antithesis of productivity. So we need to support the sector, and government needs to be much more effective, play a much more effective role to have a well-designed system that's able to be productive. But then, as Rachel Reeves said, and then the Resolution Foundation and the LSEs have also said, we also need to be realistic that an economy can't all be high-end manufacturing and high-end services. We all need to get our hair cut, want to go out to dinner, have social opportunities. We want to be cared for. That's part of a well-functioning economy and society. And those things we will have to pay more for. Yeah. Now, if we've got the other parts of our economy going well and a social care sector that is able to be as productive as it possibly can be, then we are in a virtuous cycle in our economy. At the moment, we are in the vicious cycle, yeah, and we need to switch out of that. But I think you can see that there are lots of potential reforms which wouldn't some of which wouldn't need more money from government, which could help the social care sector to be more effective, to be more productive. But then we also need to be realistic. We have an ageing population. We want an economy which is high performing, but also which isn't reliant on people in the everyday economy having appallingly low wages so that everybody else can have a good life. We need a fairer economy as well. And that will almost certainly mean that we will have to spend more on social care. But we want to spend it on a productive social care system that supports our economy and supports individuals well.
Thank you very much. Plenty of food for thought, and certainly a picking list of things we can recommend to government is what we're looking for. So much appreciated. Ben Common.
Yeah, no, thank you very much, and it's great to see you all. And I should say that I've had the pleasure of working with Anita on the North West England Integrated Care Board as members, and I've known Emily for many years in the work she does for carers. And it's just Oonagh, good just to meet you properly. It's very interesting to hear the link, how you're making the link between economic growth and caring, and of course social care, and of course social care also provides a lifeline. It's essential for unpaid carers as well. And I just wonder if we can would like to say anything more about the impact of good social care on economic growth in the regions particularly, whether there are particular parts of the country which could do with an improved approach that would help achieve more growth in that region, that part of the country.
can I just start by setting out sort of a principle about economic growth and unpaid carers? It follows on from what Anita was saying about everyday services. We look at childcare, for example, as being a fundamental condition for parents to be able to work. That's really clear. The economic links are clearly made, but we don't make the same link with social care being a fundamental condition for disabled people to be able to work and their families. And when we look at labour market statistics, we see an employment gap, a quite clear employment gap between people who are caring and people who are not caring. And people who don't have the means to purchase their own care, we start to see, as Ben said, a regional impact, for example. Post-industrial areas are much more likely to have high areas of ill health, disability, and we see different clusters of poverty and carers allowance. But coming back to the economic growth point, this is really critical because we see in terms of carers' work patterns that even caring 5 hours a week can have an employment effect. And it is differentially felt as well by women. And I think this is a really important point, that you have a 50-50 chance of caring by the time you're 46, the same chance when you are 57 and a man. So there's 11 years difference between a woman's chances of having their work impacted by caring and men's chances. And when we're looking at the economy, that starts to make a real difference regionally and personally, and also in terms of class and opportunity, which links to 3 of the government's missions: health, opportunity, and growth. Actually, it should link to all 3. So we've done some analysis recently of carers in poverty, and this is one of the costs really when people fall out of work. Falling out of work perhaps is a bad term. People get to the point where they just can't manage anymore juggling work and care, and they give up work to care. And we start to see some of the impacts on people who then have to rely on carers allowance, which is the lowest benefit of its kind. And we see 1.2 million unpaid carers in poverty and 400,000 in deep poverty.
It's obviously very worrying. Is this because they prefer to care than have the person they're caring for looked after by social care, adult social care, or because they can't get the adult social care, or for other reasons?
Yeah, it's a combination. So about 62% of people say they have no choice about caring because no other alternative care options were available. Some people wish to care, but there is also a lack of care, and some people who need care don't want to be cared for by anybody else apart from their family, and that's a factor. I think in about a quarter of people. If I've got that wrong, I will write a note to the committee. So it's not straightforward to say that people don't have a straight choice. There are cultural responsibilities as well in all cultures about caring, and gendered perspectives as well, which place sort of duties, especially on women, to provide care. So, but I think this whole intersect between carers' work and social care and disabled people in social care is under-researched, and we don't see it referenced in many government documents, and we should.
Thank you. That's very helpful. Anita, can I just pick up a couple of things you said?
Yeah.
Everything you're all saying is very interesting. A couple of things. You talked about commissioning in a different way. And you also said, that we're commissioning different, and you also said that not all reforms need more money. I just wonder if you want to unpack those.
Okay, so in terms of commissioning in a different way, and I don't have a fully worked up model, but I do think that this is a really important issue for the Casey review to look at, and to look at early, because this is about getting more value from the funding that we currently spend, and unlocking some of that. There are some examples as well around the country. So Leeds has tried to do a lot of work on different approach to commissioning social care. So there are a couple of things which I think are really important to think about in commissioning in a different way. What is the extent, the amount of the duration of the contracts? So if in other public services we've recognised that if we give people contracts for longer periods of time, so we give people some financial certainty for a period because we're very confident that we're going to need some capacity. Yeah. If you get a contract for 3 years, yeah, what you can do in terms of the staffing, the model for your staffing, your incentives to train and develop your staff, your ability to access capital at lower rates is very, very different. There are other government reforms looking at, for example, on the local government pensions side, trying to unlock some pensions money for more for investment. Yeah, that will be lower cost capital. If we could think about the way in which we contract for social care into models which are attractive for that longer term patient capital, that should potentially be a lot cheaper. The other thing, though, is contracting for outcomes rather than contracting for activities. When you contract for activities and tasks, it's very difficult for people to innovate. That's important for things like digital and trying to think about new models. And there are some examples, most obviously the Netherlands ones, Bezutzong, which have tried to bring together and come up with some more outcomes-based contracting where there's more innovation, more flexibility for providers to meet needs in different ways.
That's helpful. So, yeah, Oonagh.
So I was just going to come in and pick up on the Leeds model, which I think is a really good example. So in Leeds, they're moving away from a time and task approach, building in integration, working really well between health and social care, which we talk about so much. And what that means is that the workforce is given more autonomy, more flexibility. We're trusting the workforce to use their judgment more in terms of how they're supporting people, and allowing people to be supported in the way that they really need to be. And from a workforce perspective, that includes things like paying for whole shifts. And we know that one of the things that impacts on the turnover in the workforce is the balance between flexibility and stability. If someone is on a 0 hours contract, they're much more likely to leave an organisation. And over 30% of our care workers are on a 0 hours contract compared to 3% of the broader population. But that Leeds model in the first 18 months has resulted in 1,200 fewer adults being admitted to hospital as well, and the length of stay for people requiring support on discharge was reduced by 17%. So there are real preventative savings in terms of that tertiary prevention, people going into hospital, and real impacts on the workforce as well. So there's really good pockets of and examples of really good leadership and innovation, and the more that we can pull those out, the better, I think.
It's also giving us a baseline of what we could compare to. I mean, is there anywhere else in the country we should be looking?
Sheffield. Similar model, Hammersmith and Fulham in terms of the funding model there. There's so much really good practice sitting across the country. It's the point that Anita made, which is we rely on pockets of really good leadership, and what we want is the whole system to be supporting some of this where we see that it works.
Thank you, and thank you. I want to be clear, I haven't primed Oonagh to say Hammersmith and Fulham. I'm very happy that she did. We touched on you touched on the government's role, and just going back to economic growth, because that's what I'm focusing on. Do you think there is enough consideration being given by the government to the contribution of the adult social care sector when it thinks about economic growth, alongside the debate about reforming the sector? Do you think the government gets the role of adult social care in supporting growth? And if not, how could it be encouraged to do that? And that's one for everybody, really.
If I start, it could do more. It could do more. So if we're looking at the Get Britain Working paper, for example, and people's ill health, there's quite a significant group of unpaid carers who've also got ill health as a result of caring, who end up in this group. And this is, again, the disability sort of a employment gap as well, of where people have become ill or disabled later in life, as well as, obviously there are key issues for people throughout their life. But they could do more. I think we have the DWP perhaps who might understand this best, because they're concerned about benefits bill and making sure that people have the biggest opportunities. We know that carers allowance is the lowest benefit of its kind. It's only £81.90 a week for 35 hours of care. I don't think the Department for Health and Social Care really has fully explored this relationship, because of course carers support, if you put a price on that, it's 152 billion a year, but that's not free care, if you see what I mean, because of the negative aspects of this. And I think a dialogue between Treasury, DWP, the needs of employers actually across, UK PLC really, across the country also need to be considered, because they are losing valuable employees. Around 600 people give up work a day in order to provide care. And social care will play an important role in that. Just looking at our members, for example, who are unpaid carers, 69% said social care helped them to juggle work and care, and they're often providing very substantial amounts of care. And 50% of carers who had given up work to care couldn't find suitable care to return to work. That pathway is incredibly difficult for people around predictability, and whatever I say for carers is true for disabled people as well, perhaps more so. And 40% couldn't find affordable care. So we need to understand this intersect much more. There was a task force which looked at this in about 2013, and there was much more interest in 2009-10 around the last white paper on social care, where I think we saw an understanding that with the ageing population, rising state pension age, productivity issues around workers, and different industries, that we need to keep people working for as long as possible, and one of those things is social care.
Thank you.
And Anita, that's very
so I would say to add to those points, the extent to which, and I think it'd be really important, we don't yet, I don't think, have the terms of reference for the Casey review.
Not that we've seen either.
No. But actually having the productivity of the social care sector and what we need to do to support that squarely within the Casey review is really, really important. And I think, and I'm hoping that aspect of the work could be fast-tracked rather than the full 2028. And I think that's really important, because the introduction, obviously, of the fair pay agreement for social care is a really important moment for the sector. But as is often the case, the impact of that will depend on the other things that happen around that. So making sure that those wider reforms are in place is really critical. The one other area where I would say that at the moment you don't see so much on the opportunity side is thinking through the impact of being a young carer.
Yeah.
And this is smaller numbers but very high impact. And we've known in a number of areas that if you have experiences in late childhood and young adulthood which affect your education, your mental health, your ability to work, that's not only wrong in and of itself, impacts you in the moment, but it actually has what the economists called a scarring effect, that actually if you don't get a firm hold in work with the education behind you and good well-being and mental health, you never get to where you were going. You never reach your potential. And that is a smaller number of people, but the impact on them of a lack of support to be able, to have good mental health and care without affecting your education and your work, it is something in terms of opportunity that we should really be concerned about.
Thank you. We are going to move on to carers and workforce and everything, so I'm really keen to get to all of the questions. So, Paulette Hamilton.
Right, my question is around unpaid carers, and for many years, just to preface before I bring the question in, for many years as someone who led adult social care, we couldn't manage the system in Birmingham, where I was the cabinet member for adult social care, without unpaid carers. They were an army of people. I heard what you said earlier, Anita, but to be honest, it was more the unpaid carers that kept us going than the people we actually paid for their services. So the question I'd like to ask, and I'd like to ask Emily, and if Anita or Oonagh wants... Oonagh wants to come in. I knew I'd get that wrong. Anyway, sorry, Oonagh, I won't get it wrong again. I'd be really happy. The question is, how sustainable is the current level of unpaid caring activity? How sustainable is it for the future, the way that it's going at the moment, taking into consideration what you said about cultural issues? Because in areas where you have large Asian communities, large communities, they look after their own predominantly. We still have some, but predominantly. So how is it sustainable for the future? Starting with yourself, Emily.
Well, thank you, Paulette, and thank you for really recognising the role that families and close friends play in the whole sort of economic side. We really value that. It's not sustainable now, and as I said before, we see poverty impacts for families, really significant poverty impacts. We see health impacts. Again, there's a poor health gap. We see there's a study in the US which suggests that carers have a 63% increased mortality when and we have sort of work impacts. Some of our members are saying, well, we've spent all our money now. I have nothing left to pay for my own care in the future. We have people, carers feel very concerned. 3/4 are at breaking point, don't know how they're going to manage in the future. And of carers who are in very bad health, mental health, about 1/3 had considered, had thoughts of self-harm and suicide. So when we're talking about sustainability, we can't look at the current system as sustainable even now. And I know that you know that, because when we look at ADAS, the Association of Directors of Adult Social Services, survey figures last year in terms of growth and demand, they're seeing, and you will have seen this in Birmingham, I'm sure, carers coming now with much more complex needs. They're reaching a higher level of need and at breaking point. And this is, it's a travesty. Families need more from systems and support. Sorry, I've lost my train of thought.
But that is fine. I'm going to bring Anita in quite quickly.
Yeah, and I think actually it's really important that we don't see unpaid care and the paid for social care system as direct alternatives. If we have an effective system, they are, for most families, they're working in partnership. But from the census data, what we have seen between 2011 and 2021 is a growth in the number of people who are doing very high numbers of hours of high intensity care. So the numbers providing 20 to 49 hours have increased. The numbers providing 50 hours or more a week have increased. And the number of people number of carers that local authorities are able to provide some support to has declined. I guess, so one of the concerns here it is that model that essentially reduces and this is not because local authorities have chosen to do this, have concentrated their efforts on some high-need homeless patients, had to reduce, therefore, some of the lower-level interventions that probably made something quite sustainable for somebody, so that people, informal carers, are finding themselves doing more and more hours, doing types of care that they find difficult. And there are a couple of areas where I think we really need to think about this. One is we've got more younger adults who've had caring needs, from childhood or young adulthood, who are living much longer. They've been cared for by parents. Those parents are now becoming elderly, very, very elderly, developing some health and issues of their own. So, that care, the care that they were providing becomes unsustainable. Many informal carers also are a fellow elderly partner, and there may be some things, cooking a meal they can do, because a point where trying to get somebody into the bath or whatever, and the lifting is unsustainable, and they themselves fall. So thinking through who's caring and how we make sure that the paid for social care is targeted at the right things that make caring something that people can do and manage where they and their loved one want that to happen, rather than seeing them as always just sort of alternatives, I think is very important.
Thank you. Did you want to add anything on?
I just wanted to give a bit of a story about the actual impact that, Emily and Anita have covered it really well, but I was speaking to a woman a few years ago whose husband had more than 100 carers in their time, and he had dementia. And I say that because it's not either or, it's both and. Even when you have formal care, the impact on the individual family carer can be significant, and the impact on the quality of care and support and on people's lives. Our lives are complex, and it's if everybody has a slightly different sense of what they need for their own well-being, and that combination of formal and informal care need to work really well together. And I think that's a really important point for us to think about when we're looking at the growth that we need in terms of the paid social care workforce. That's going to be a really important element where, if we can't get that growth, that will have an impact on unpaid and family carers.
Very good point. Oh, sorry, Emily. Can I just add a little bit extra?
Yeah.
For the future, we have a risk here that adult social care, if we continue to rely on unpaid carers, how are we going to quantify the risks for the future? Because the way social care is going, and it's falling down, and everybody admits to that, but these unpaid carers can't carry on. So for the future, are you able to quantify what the major risks are for the future? I'm a person of numbers. So if you just think about 2 areas where you think there'll be a major risk in the future if we don't sort out that way of work, that those unpaid carers who are struggling, who have got mental health issues, who have ended up, in poverty and what have you, how are we going to work with them in the future? I hope that explains it, but
it does. It does, and I just wanted to say, that good quality social care. I just wanted to say that it is transformational for people. Yeah. It really is, and I know from my own family, and I know from friends, and I hear it from our members too, that it doesn't just, it's about quality of life, it's peace of mind, and then it's health and well-being, work, relationships, reducing loneliness. And it's not a nice to have. That has an economic impact, as you said. So I think the 2 risk areas are to health and well-being. We see that really clearly. The biggest growth in the numbers of unpaid carers are those women over 85 who are caring over 50 hours a week, having to do, that's a lot, as you were saying, in terms of what people have to do. And the other area is the labour market. So if we look at the cost of loss to the economy, Centrica suggested that unplanned absences cost the economy about 4.8 billion a year. They grossed up, they looked at their own figures. This is an issue which will also roll into things like
absences due to caring.
Yes, unplanned,
specifically.
Yes, unplanned absences due to caring. Now, some of that will be down to social care, but Paulette, your point is broader than that, isn't it? About caring and people's lives. So we need to look at the cost to business of this as well, and people caring business and public sector employers. The NHS, the staff survey showed that 1 in 3 of their workers is also an unpaid carer. This is down to women, ethnic balance, and age. That's why it's so high. And so it's really labour market and health and well-being.
Thank you for that, Emily.
Yeah.
Can I go straight over to Anita? And I'm going to ask the same of you, Oonagh.
Very brief answers.
Yeah, I always do 2 points, so without all the explanation in between would be helpful.
Yeah.
Thanks.
Given our demographics, we need to make sure that people between the ages of 50 and retirement age are able to work and work in a sustainable way. We're very focused at the moment, rightly at the moment, on the impact of their own health on their ability to work, but we also need to worry about making sure that their caring responsibilities are also properly addressed. And often those two are related, aren't they? Because it can become, you're caring, you become ill. And once people leave employment between those ages, returning to employment is incredibly hard. So the other thing that I talk about all the time, prevention.
Final word?
I have nothing to add.
Brilliant, thank you. Back to the chair.
Thank you, Dr. Becky Cooper.
Thanks so much. So we're going to stay with unpaid carers, if that's all right. And I just wondered, listening to the numbers and the census conversations, are you able to give us a number about how many unpaid carers there are currently?
Well, it really depends which survey you choose,
Okay.
because they have slightly different questions
top
and
3, yeah.
slightly
What are your
different
numbers?
answers.
Yeah.
So if we look at the census, it's 4.7 million in England.
Okay.
The census question changed, so we actually had a drop in the number. Scotland did theirs 1 year later and had an increase. And they used the same question as before. So there are slight differences in questions that you ask. As Anita said, what we saw in the change between 2011 and 2021 there was actually an increase in substantial care. And there was also, that census also returned results where there was a drop in disability. So you see that's a sort of, we're seeing that as a slightly sort of different type of result. If we go to the GP patient survey, for example, they suggest there might be around 16% of the population, sort of 9%, 16%. So, and some of our surveys return when we do polling between around that level. So there could be as many as over 10 million or 8 million. The bottom line is there are millions of people doing this, and each data set has its own merits at looking at different interactions. So there isn't sort of there's rarely one figure, if you like, but just taking the principle that it affects many people. If we look at the churn on and off, I will also want to say it's not a static figure either.
No, I appreciate that. It is interesting that it's so broad, because obviously we're calculating based on presumptions, but you look like you've got a ballpark somewhere between 9 and 16%. There's sort of there's a range there you can be relatively confident in. Okay, thank you. So if we're looking at that number, and then I'm thinking about the Casey report, what are your thoughts about what social care reform should actually deliver for unpaid carers and also for society as a whole in terms of care? Is your opinion that we should be looking to reduce the number of unpaid carers. So we should be looking, I mean, you talk about sort of targeted social care. I've heard that very much about the right type of social care being provided, you know, and commissioning in an outcomes-based way. I appreciate that's difficult, but I think it's laudable. So should we be looking at reducing the number of unpaid carers, or should we be looking at, you talk about the benefit for carers at the moment being low. I know the sort of employment earnings limit has been announced as an increase this week, the DWP. Where are you sitting on that spectrum in terms of what you think should happen in this reform?
So reducing the unpaid, I mean, at the end of the day, this is a choice, even if some people don't feel they have a choice about caring, and particularly about, you know, when we look at young carers, it's a very good example that what we need to be doing is giving people the right opportunities in life to work, to connect, to be well. And families will still care. A lot of people will still choose to care. So I think government's role really is to support them to stay and work, to support their education, to support their well-being. And that will be different for every family. Some families might decide to do it all themselves. Others need more support, and for a whole variety of different reasons. So I think that's very important. And so the broader aspect of this is absolutely critical for us, and social care is one point there. Workplace rights is also important. You know, the flexible working rights that are coming through the Employment Rights Bill are very important. In the future, we'd like to see paid carers leave, so that we turn the unpaid carers leave entitlement, which, you know, the last bill brought in, which is very important, turn to paid. And we need investment in social care to reduce those health impacts of caring. And we can't leave families in poverty because they're unable.
Okay, so it sounds like you're talking about broader reforms generally.
Yes, for us it has to be. It has to be broader,
and I understand that. Oonagh or Anita, is there anything you?
I'd add one thing. I think looking at, well, there are two things that I would add. I think this issue of more and more of the formal social care system being devoted to people with very high packages of care, yeah, which has reduced the amount of lower level, if you like, interventions, both earlier interventions and lower levels of support. Now, that's a completely understandable change when you've had funding constraint. But often, obviously, what that may well affect is the sustainability of the informal care. So really thinking through, it's unlikely, I think, that most people who care will choose will elect no care at all. But the extent to which doing 50 hours a week of care can be seen genuinely as a choice, some people it will, but many people are doing very high intensity, both in terms of hours and types of tasks, that, you know, if they had appropriate support, would free them up actually to have more of the time and relationship that they would want to have, that they, as the person's loved one, uniquely bring. So I think that's something that I hope the Casey review will look at, and how you can do that. The other thing is that the Care Act, again, I was just trying to look through my notes, I can't find it now, did include provisions to support informal carers. And I think the extent to which local authorities have been able to actually really implement that in the spirit in which it was intended is limited. And I think if you were looking at somewhere where you'd really want to focus early, it is on young carers, and say, actually, if we were prioritising, and inevitably we will have to prioritise, you know, to what extent are we being, especially with outreach. I mean, one of the issues often is if you're a young person, you're trying to do, you know, finish school, you know, look after your parent and all that. The idea that you've got time to devote to trying to interact with the public system to get what you're entitled to is not really very realistic. So how we reach out, there's a multi-agency activity to reach out to make sure that young carers in particular getting the support they need, I think there's something very important to think through.
Okay, and I will stop now, but it does, I mean, obviously it's very substantive, the question, but it does sound, you're talking about making the case for reform whereby unpaid and paid, they're on a spectrum, they're both vital, but it is that thing about if you're the unpaid carer, there's the choice to be able to have your good quality of life alongside caring for your family to the extent that you're able to. And that sounds like it'll be the best return on investment for the country as a whole as well.
Yeah.
Okay, thank you.
Thank you, very clear. Quick, Stafford.
Thank you. And I'm going to, my questions follow on from the ones we've just had. You've talked, I think, very eloquently and passionately about the effect that this is going to have on carers. I'm afraid I'm going to be a bit more hard-nosed in my questions and get down to the money side of it. So have you done any assessment of what is more cost-effective to the economy as a whole, having unpaid carers with the support packages that you're talking about versus having fewer unpaid carers and having the social care in its general sense, professional social care, pick up that cost?
I haven't seen any modelling like that. I think it would be an excellent thing to suggest that the Casey Review does, to set out that business case. I think it's really important, though, that business case isn't just an immediate short-term one, because some of the things that we're talking about here, and is quite important, is if you just have a short-term problem, you might say, let's ask people to bear a bit of a heavy load. But actually, we've got profound demographic change, which we're on the cusp of, major changes as well in our economy, linked to that demography with fewer young people, a desire to reduce the amount of inward migration. We need to increase our employment rate and make sure that, and so, if we have high-skilled people in occupations where we cannot, at the moment, employers can't find people, and they're having to leave the labour market 15 years early, to do unsustainable levels of caring hours. If you look at that over the long term, that is, what my granny would have called, penny wise and pound poor. And so I think it really is important that if they look at this, they look at this actually as this is a one-off opportunity for long-term reform at what is in the long-term interest of our economy.
It's really helpful. Any other thoughts? I mean, I know there are no studies, but what's your sort of personal and experiential view on that?
Well, we hear a lot from our members that some of them who do have more income and cash can't find care. So the investment in the workforce is absolutely critical. It's no good if you can't buy it, and it's not the right kind of quality, as you said, the task-based approach. The stories from our members too about the being exhausted by different people coming into the house, and the sustainability of packages and relationships is so important for the person they care for and them. And when we get poor quality care, they refuse it. They don't buy it. They don't use it. And that puts them in a very difficult position. I would also say that there is an economic value as well around the disability movement and having choice not to be cared for by parents, brothers and sisters and families, that they've fought very hard for that right to live their lives as they wish to. And equally, not all carers want to care for relatives, and some shouldn't be caring for relatives as well, where they have perhaps come from previously abusive relationships. There's a finer point to this around rights as well as your economic question.
Yeah, no, accept that. Thank you.
The only thing I would add is that as we start to look out longer term, and this is one of the benefits of a long-term review with the Casey Review, is that as a society we need to be thinking about what's the role of prevention in some of this? If we prevent need by preventing ill health, or we reduce the draw on social care by primary prevention or new models of care, and then there's a real impact on the workforce. If we don't do that, then we've got some choices to make. We can grow the workforce, so from a formal kind of workforce perspective, we can grow the workforce and meet the changing needs. We can not meet changing and growing needs, and or we can rely more on unpaid carers. And they are the choices that we have to grapple with as a society when we start to look at what social care is in the future. And we're looking at a 15-year horizon, but it's happening now. And so the importance of that long-term view with immediate medium-term and long-term action is really important, because we do have a limited number of choices, but we've got to make them.
Okay. And so when we look at the sort of from the financial perspective, I think there are various figures, but around 180 billion pounds are contributed by unpaid carers to the economy. If your sort of suggestion, I think, was that we want to move away, as if they don't want to care, then we should build up the professional care system in order to replace them. If we did see that and we saw a reduction in unpaid carers, what do you think would happen to that 180 billion? Would it get redistributed within the economy, or would it just be lost?
I don't think we'll see a reduction in what people do. There was a small study done when Scotland brought in free personal care. How did families react to that? They didn't actually reduce the amount of care. What it changed from was some very fundamental care tasks that are very task orientated to things that you would consider to be part of family relationships, the social stuff. Yeah. Because if you've only got 3 hours in the day, you have to get the most demanding tasks done. You don't have time for socials. So, and we know how much loneliness and isolation affects disabled and older people, and how there are clear health benefits to making sure that people aren't lonely, and quality of life makes a difference. So, and there are no other countries around the world where we're seeing a reduction in care when people have introduced. If we look at the movements, for example, in Germany and Japan, investment in care was largely driven by labour market. It was not largely driven, but it was definitely a factor for that was labour market participation, women in particular participating in the labour market with the ageing population. So we still will expect to see an increase in what people do. It's just the level of care that people have to provide is the critical issue.
In that Japanese model, did it work?
I think, they're into a super aging society, so every country still has shortages of social care and challenges around those areas. And Nuffield Trust have done some very good investigations into both of those systems. So if you wanted more information, I'm sure they would be more than happy to supply that to you.
Anita, did you want to come in on that?
Well, I guess one of the things that it's important to say is, and we're sort of be doing here, is a lot of the estimates of the economic value of care are based on estimates of, if this was done by paid staff, how much would it cost? Yeah. So obviously, if we did shift the boundary between informal care and formal care, we would be bringing into GDP things that at the moment aren't in GDP. Yep. Yeah. Now, I mean, that's just an artifact of the fact that GDP is an imperfect measure of what we do. I guess the question is, would that be a better economy which is working better to meet the needs of its and desires of its population? Yeah, and I think there isn't any modelling study, but I think if you follow this through, and it does seem really important now, we are going to have more older people who need care. We're going to have more younger people who need care. We need to do lots of prevention to make that as minimal as possible. But there is no escaping that demography. And we're not running that well for anybody at the moment. And so we do need a fundamental change here, because this problem is not going away, and ignoring it just makes it harder to fix, not less. And part of the reason why we've not had reform is that each year we don't reform, the costs go up, the challenge from where we are to where we want to be gets bigger and bigger.
Thank you very much.
Thank you very much. Jen Croft.
Thank you, Chair, and thank you for being here today. So I am quite interested, a few of you have mentioned the poorer health outcomes for unpaid carers. Just interested to drill down into those a little bit more. What is it that causes poorer health outcomes for unpaid carers?
So just the sort of poorer health outcomes that we're talking about, if we look at the GP patient survey, they have higher percentages for mental ill health, musculoskeletal, so that's moving people around where they strain there, and blood pressure is higher. So that goes without saying. Mental health is because they're unable, they often put themselves at the back of the queue, so their primary concern is about the person that they care for. The mental health and well-being is the challenge, stress, lack of time off. If you ask them what they really want, if you're asking carers with substantial care what they would really like, top of the list comes a good night's sleep. Then breaks to be valued actually and recognised, and they're quite fundamental things perhaps that other people don't understand. You can imagine somebody in their 80s looking after a partner with dementia and having to get up several times in the night. Some people, working people, do that and go to work the next day. So that's why they usually display these additional areas. So we also have where people have other pre-existing conditions as well, perhaps arthritis, and they are doing a very physical job of caring. Those conditions are then exacerbated. Of particular worry, we know that 44% have put off health treatment as a result of caring. That's from our members who are providing very substantial care, and 70% have cancelled appointments or scans or treatments. So it's a bigger number because they've had to shift things around because of caring. So their ability to look after themselves is hugely reduced. I won't go into the link between poverty and ill health, but that of course is another factor in this. Their ability to take time, so they're time poor. They can often have very physical caring, and some people talk about it being endless, without a break. So those are the different reasons. Does the NHS really recognise caring? There, you can get flagged on your patient record whether you're an unpaid carer or not. There are some positive health measures that you can introduce, like health checks, but the NHS could do a lot more for unpaid carers.
Thank you. And is there any kind of, are we able to quantify that cost of sort of increased unmet health needs on unpaid carers, or is it perhaps too vast and wide?
Yes, we are able to quantify. There are very few studies that have been introduced looking at sort of control samples are incredibly difficult when we look at these sorts of situations. The best you could do is sort of looking at carer versus non-carer. But there are studies to show, for example, that breaks reduce cortisol levels, which are directly related to different health areas. So again, breaks make a huge difference to people. They are in very short supply. We have carers that 54% haven't had a day off in the last year when they're providing very substantial care. So I can see Anita wants to say something.
Yes.
Come in.
So there is a study by a team at the LSE, Nicola Brimble, who I think has submitted some written evidence to you that looked at the costs for young people who were caring, and that's young people aged 16 to 25, and she found an overall cost of £1 billion, and I think about a quarter of that was NHS costs. And I'll share the link with the study with the team.
And what I'm kind of picking up from what you're saying is one of the things that might be helpful is resetting that relationship between formal care and unpaid carers. Perhaps bringing unpaid carers having a better seat at the table or more parity of esteem. What would that look like to you, and how would that kind of work in practice? Is there anything kind of practical and not small but practical that can be done to reset that?
Yes, if you ask them, they have a very clear idea about what that is, about being valued and recognised. And it is being treated as a partner in care, but also having choices, not making an assumption that you would do this. And Paulette mentioned cultural differences. That's also really important. Not an assumption that different cultures will look after relatives, but actually how to introduce help and support that is acceptable and helps people that really need it. But part of the reason why this relationship is difficult at the moment is because social care is underfunded. So as soon as you introduce better social care, the Care Act is a really good piece of legislation, really great, providing adults with good rights and entitlements, but local authorities can't deliver it in the way that it was intended because of a shortage of funding. And so we're left in this situation where carers are ignored. So if we look at hospital discharge, for example, the rights and entitlements, we've measured them for carers with substantial caring responsibilities, and only 14% at the point of hospital discharge received the right amount of help and support to help them care safely and well. So, a hospital discharge is highly pressurized environment, and if the relationship between carers and services would change. I do think that the NHS needs to do more, and when we're looking at the 10-year plan, to recognise and support carers, because that will automatically help to reduce the health and well-being impacts, as well as help social care, if you see what I mean. It's often we look at social care helping health, but we should be looking at the other way as well, how the NHS can support social care.
And is that, so with the NHS supporting social care, is that, you mentioned health checks for carers as a potential idea. Is there something around that that's more treating the symptoms of having a kind of almost a social care system that's not working? Is there something that can be done to kind of redress that balance, rather than treating sort of mental ill health, musculoskeletal, all those kind of things that we know are risk factors? Is there something, is there more in that sort of prevention side of it?
Definitely. I mean, it's people often come to their rights and entitlements too late. So it's about income maximisation. It's about activating your rights. Just, for example, what rights do you have in the workplace? Can you activate them as well? But it does also come down to the kinds of support, good quality support that you can rely on. And good news travels well as well. If you have a good experience, you share it. If you have a poor experience, it also helps to put people off care or certain paths. And people need to be secure in the fact that they've got we haven't talked much about sort of workforce strategy, but that's absolutely excellent. I won't talk about that then.
Good segue.
But those areas, and some of the aspirations to reduce the number of times that you have to repeat information, services linking up, just really simple uses of digital to be able to, carers, making sure that carers know about their entitlements really quickly. So on the back of an application for carers allowance, for example, you could encourage them to then register with their GP as an unpaid carer, link with their local authority to find out what local support is available so that people don't fall through the net. And Health Foundation did a very good piece of work, the Network Data Lab, looking at overlap between GP lists and local authority lists, and very small level of overlap of unpaid carers. GPs tend to do older carers, local authorities tend to do younger people. There's a real missed opportunity there to get this data, or to get services linked up for the person.
Yeah, thank you.
There's a bit more on data linkages that's being done. Yeah.
We need to move on.
Back to you, Chair.
Thank you. Josh Fentinglin.
Thank you. I'm going to move us on to workforce strategy. This was just trailed. But just in that last answer, you said a statistic that I think I saw 4 of our members writing down. So I just want to check on that. Did you say that 14% of people who are discharged from hospital have the care packages they need? Is that correct? 14.
I said, 14% of carers, 1/4, said that they didn't have the support and information to care safely and well for the person being discharged from hospital.
14% of carers didn't have.
Sorry, only 14% had. Sorry, beg your pardon. Had, yes.
86% didn't.
Well, I can't say that categorically.
No, sorry.
No, 14%. So the rest.
Just to clarify the statistic, because it's the kind of thing that may end up in the report, but that's the carers feeling they have support. So people may be getting the care package, but the carers don't feel they have the support or the kind of idea of what the care there.
Yes, so that 14% were getting the right care package, the right level of information and advice, and that's 14%. So the rest, about 56%, disagreed with that statement, that they were getting the right level of support and care. So we've got a large amount of people who are managing at the point of hospital discharge without the right care, without the right information advice.
I would love it if you could send us some further information as to what that 86% looks like, just so that we can get an idea of that, where we're not getting the care right and what that means in terms of hospital discharge. I'm going to move on to the workforce. Obviously, Skills for Care did a brilliant state of care report last year, which I've brought up at this committee a few times. One of the things that came out of that was the 8.3% vacancy rate in social care, so 131,000 vacancies in adult social care. What is it that's driving these vacancies?
I think it's probably important to start with the impact of a high vacancy rate, just to...
That's my next question. So what's...
I'll move past that.
Okay.
That's fine. So what's driving the vacancy rate is really 2 things. It's attraction and it's retention. Yeah. Some of the vacancy rate is really positive. So some vacancies are really good. It's because of, it might be growth, additional needs being met, but our report shows that the vacancy rate in adult social care for the full year that we have the data, up until March 2024, is about 3 times the national vacancy rate. So while some vacancies are good, it's still much higher than the kind of general economy. So there's probably 2 questions. The first is what stops people coming into social care in the first place in terms of roles. And we know from our data that the biggest indicator of whether a provider is going to be able to fill vacancies is the ability to compete in the local labour market. And that does include pay, but it's not just pay. It's how we talk about social care, it's how we value social care, it's differentiating social care roles from other similarly paid roles. And that... So when we need to tell a different story about social care as a society and as a sector, and we're starting to do that. So one of the questions that Ben asked earlier was, does the government view adult social care as part of the growth agenda? And I think that when we look at the Secretary of State saying, this is a growth department for the Department for Health and Social Care, I think we're saying that more and more. I think the sector is saying that more and more, and we can do more to talk about social care in a really positive way, that there's a high vacancy rate, about 131,000 vacancies in any one day. Well, let's start talking about that as 131,000 opportunities to work in excellent roles where we can give purpose and we can give flexibility. They also need to be good quality roles. So there's an element of competition in the local labour market and the view of adult social care, which could be linked to the fact that as a society, the people that we support aren't always valued. So older people and disabled people aren't always valued as a society, and so is that one of the reasons that social care isn't valued? So we need to tell that story more. And then even when we do get people in, because we recruit a lot of people every year, more than 300,000 new starters in social care, but we've got a bit of a leaky bucket, so we don't keep them. And even though, so turnover has reduced in the year 23-24, most of that is down to international recruitment, because international recruits are less likely to leave their roles in year. Our data, which we collect from the adult social care workforce data set, which covers just over half of the sector, when we did some analysis looking at what are the factors that influence turnover, if 5 conditions are in place, then turnover halves. So if somebody's on higher pay, if they are not on a 0 hours contract, if they are able to work full time, if they have access to training and a relevant qualification, turnover goes from 40% to 20%. You add to that the impact of culture and leadership, which we know is really important, and we can see that the 3 things we need to do to keep people is we need to focus on quality of role, and that includes terms and conditions, it includes stability in role, it includes a lot of the things that the reform agenda should pick up in terms of the Fair Pay Agreement, the Employment Rights Bill, and some of those labour market conditions, if we train people. So quality of role training people, so that the skills agenda is incredibly important, and then organisational culture and leadership. They're the 3 factors that will most impact on whether we can keep people in role.
I think that's reasonable. I used to be a cabinet member for social care. Like many on this committee, I'm a recovering local council cabinet member. We tended to find people would come in from retail and leave to the NHS. We talked about the 8.3% vacancy rate in social care. I think it's 2.3% in the NHS. What do we do to make social care a bit more sticky then, and make it, and not, you talked about the training. We found we'd give people brilliant training, and then they could go and be HCAs on NHS pay bands.
Yeah, I mean, the Health Foundation did some research that showed as a sector, when people join us in social care, they're more likely to join us either from another social care organisation, because about 2/3 of people will be moving around the sector, but they're more likely to join from hospitality and retail, and more likely to leave for another caring profession, which includes children's care and the NHS. An element of that is pay. So a healthcare assistant with 2 years qualification will get about £1.45 an hour more than somebody working in social care. There is an element of that movement between social care and health that we will want. We will want to see, because
there's only one way at the moment.
But it needs to be. That's the point. It needs to be. We need to be getting more people into social care, and it needs to be 2 ways. I think we've got to embrace the fact that as social care, we've got a lot to teach as well as a lot to learn. And in social care, we see people's needs through the lens of their whole lives, not through the lens of a disease or the lens of a health need. And so the benefits of people spending some time in social care is absolutely massive when we look at the prevention and personalisation agenda. But what we've got to do at that system level, so at the ICB level really, is to make sure that when we're looking at one workforce, that it's not just a one-way draw, that we are, where possible, aligning terms and conditions, making the roles as attractive in social care as health, and sometimes making the most of that transition between the 2, but so that it isn't just one way.
So going on to the question that I trailed earlier, we're thinking about the impact that it has. I think the ADAS survey at the start of last year, from January to March, said that there were 161,000 unfilled hours in social care. What impact does that vacancy rate and the turnover have on the workers and also on the people receiving care?
I should say that we've started to see a reduction in the vacancy rate since the 23-24 data. So it was 8.3% in 23-24. It's now stabilised at around 7%. It was dramatically reducing with international recruitment, and now it's stabilised at around 7%. So I should make that point. There's two impacts really. There's the impact on people drawing on care and support. If we can't fill vacancies, we can't meet need, or we're providing support but not enough support. So I spoke to one young woman who got social care support and said that she often had to choose whether she had a shower or saw her friends because she couldn't do both, because she couldn't fill the hours, she couldn't recruit enough personal assistant support. So it wasn't that the funding wasn't there, it was that she couldn't get people to fill the roles. And then I spoke to a young man, a care worker, who got quite upset, saying he was going to leave his role, not because he didn't love it, because he did love it, and that was what was driving him to leave, because he said he was going away at the end of the day feeling like, I'm not able to actually give the support that my values are driving me to, and what it's meaning is that I'm having to make people choose to eat or be supported, to see friends or to see family, and I'm finding that hard to support people to make that choice. And so what I'm doing is I'm working more hours, I'm not getting paid for those hours, I'm having to cover other people's shifts, I'm not able to bring my best self to work, and that's really, we want people with the right values to work in social care. So I think it has an impact, or it's really clear that it has an impact both on the quality of care and on the workforce. Our data shows that when you have a higher vacancy rate, then you see a reduction in CQC ratings. So there's a direct impact in terms of workforce and quality.
So just sort of thinking also, there's also the issue about caring. I think Emily talked about the person that had 100 carers. And yeah, obviously with the movement in social care, what's the kind of impact on patients of people having multiple carers, and not, that lack of retention it's having on those who are cared for?
Yeah, that example that I used, the impact on that person being supported was just not being able to build a relationship, and not the continuity of care really impacts on your quality of life. This can be deeply personal support in your private home, and so you've really the best social care support. Emily said it is absolutely transformational. But there's a real personal relationship between the person providing the support and people drawing on care and support. These are deeply skilled roles, deeply skilled in terms of communication, ability to build relationships, ability to communicate. And when you're not able to do that because you've got multiple different carers, it becomes more transactional. And the ability to spot signs. I spoke to a carer who was supporting somebody who went into the hospital, and the doctor said, "Oh, this person isn't eating. That's a symptom of their dementia." And of course, the carer was able to say, "Absolutely not. I've been supporting this woman for 2 years, and she's got a really healthy appetite. There's something else going on here." And of course, if you didn't have that relationship, you just wouldn't know that. So there's all of that intangible as well as the really tangible impacts in terms of increased recruitment costs, and it's just under £4,000 every time we recruit, and the additional training costs, but there's that real personal impact as well.
Can I just one point that I think is important to add to that? I agree with everything that's been said. Is alongside the importance of the relationship between the care worker and the person receiving care. We are for many people who need social care. They need other health services as well, and we're trying to build integrated teams and care around them. We are finding that very hard. But one of the things that's really important is when you want to build an integrated team, we often do lots on structures and funding flows, but all the evidence is that a team is about a collection of people who have relationships of trust. and that actually, when you turn over a lot of stuff, it is very hard then to make that integrated team working operate as effectively as we can. So the relationships are also multi-professional, as well as between the individual and the carer. And I think high turnover is a challenge in both areas.
It's almost like when you leave hospitals, multidisciplinary teams stop being a key cornerstone to good healthcare, which is, I think, and I assume that the high turnover also impacts the relationship between the care staff and the carers, the family carers and so forth. And does that also have an impact on the well-being of those who are cared for?
Yeah, I mean, social care is so relational. It really is at every single point, every single aspect, with the people that we support, with the families, with other professionals, also with our managers and leaders. So if we see a higher turnover in a service of registered managers, we see higher turnover overall. So the staffing relationships have a massive impact. If our registered managers leave, we see an impact on CQC ratings, and so that. You just can't underestimate the impact of that churn.
And just sort of picking up on that, obviously, I think in our heads, I think when we're talking about this, we're mainly thinking about residential care, but I imagine that's a very similar picture in care.
That's across all.
Yeah, and my final question would just be kind of just looking at what the kind of good examples of retention are. I mean, I know when I ran a care service in Coldsdale, we had a small care company, the Equal Care Co-op, which because they gave more power to the staff, but also they paid slightly higher. They had good retention. They had some really positive stories. I wonder if you could leave us with a couple of positive stories.
Yeah. So we have about 16% of our providers have a turnover rate of less than 10%. Now that used to be
16% have a
16% have a turnover rate of less than 10%. It used to be about a quarter of our providers had a turnover of less than 10%. That's getting harder to maintain. So we did some research called The Secrets of Success, and we spoke to the providers with the lowest turnover, and we asked them, what is it that you do differently? And what they said is backed up by our data. They said they actually didn't really mention pay, although our data would say that pay does have an impact. They said we say thank you. We give people autonomy in their decision making as much as possible. We develop them, and we really focus on culture and leadership. I went to visit a service in Harrogate, Vida Healthcare, and they have a very low turnover rate, about 3%. And when I asked them what they did, they said exactly the same. They really focus on the quality of roles, they really focus on training and development, and they focus on culture and leadership. So they're the things that really make an impact. And obviously some of that is easier to provide in different service models and different funding models, but they're the three things that really make an impact.
Thank you. Andrew George.
Thank you very much. And Anita, when you commented earlier, you were saying that having appallingly low wages, well, the current situation is where we're having appallingly low wages so that everyone else can have a good life. And I wanted to address the health economics, the cold health economics, not the soft argumentation that kind of justifies why we should pay care workers more. And so if we say, for sake of argument, were to model an increase in care worker wages by, let's say, 50%, quite a dramatic increase in which one might argue is socially justifiable and so on. How could we build a case in terms of productivity, addressing retention levels, in terms of pay progression, in terms of productivity and standards and so on? I mean, is there a way in which you, from your experience, knowledge in this area, believe that such a case could be made, where we could persuade the political classes to actually look at this in cold kind of arithmetic of how we justify doing that?
Yeah. So I think there are two things that we need to think through in terms of pay. One is the starting level of pay. And there is an issue as well that it isn't without consequence for the state to pay providers such low amounts that they then pay workers such low amounts, because what happens is many of those workers then end up on other forms of state support like universal credit. Many of the people who work in social care are pushed into poverty and reliant on that support. So that's not without consequence, and we need to think about that. But we need to think also about the extent to which there is progression in pay, because in starting salary matters, but actually progression in pay is really important for two things. One is for the retention, and I think Oonagh has set out a lot of the really important economic case for lowering retention. But the other thing which having progression does is it creates an incentive for someone in social care to develop their skills, to engage in training, and through that to be able to take on more tasks, to be more autonomous, to deliver higher, more skilled activities and be more productive. And then there are different sorts of training we can think about. So if we want a higher paid workforce, one of the really interesting questions, and I've not seen any work on this, and I think there's again is something really interesting to look at more systematically in the Casey review, is to what extent can we use technology and advances in technology to support social care workers so that more of their time is freed up to do the care where human care really, really matters, so they're more productive and we can afford that higher pay. Now, so that, where that sort of standalone in social care, lower retention, higher productivity case gets you. But I think what the economics would suggest, global economics would suggest, not unique to social care, is when you have these sectors where quality is so bound up with human touch, that actually there is a limit to how far machines can replace humans. And so we need to make sure that we're able to attract and retain people with the right values and the right skills. This is a really important part of our society and our economy, and the productivity gains in the wider economy enable us, if you like, then to have the everyday economy, as Rachel Reeves called it, that is well paid. Now, that matters as well for the regional picture, because Sir Chris Whitty, in one of his Chief Medical Officer reports, I think it was 2 years ago, did a really fascinating report about ageing society, demographic shift, and how people are moving around the country. And this is something as well that we haven't thought about enough then with the link to our economy, because we've got older people with higher care needs moving to rural and coastal areas. They have less of the sort of high-end strategic sectors economy anyway. If we have then all the everyday services that they rely on as rock bottom, low paid economy, we will increase our disparities, and we won't have people in those areas to do those jobs. So those wages will need to be competitive. We need to make sure as much as possible that we can make sure that we're reaping the benefit of that in the productivity of the social care sector. But actually, we are going to have to pay more.
So we have done some of that modelling that I can send to the committee. In July last year, the sector led a workforce strategy for social care, and some of the recommendations in that are already being developed by government in this space, like the Fair Pay Agreement, the Care Workforce Pathway, which is building that career structure. But what we did in the workforce strategy, there's an economic case attached to it, is we modelled various scenarios, including an increase in base pay, keeping differentials, aligning with NHS, agenda for change, paying real living wage, and we modelled both the costs and some of the impacts of that. I don't have the figures in front of me, but I'll send a note to the committee.
That'd be really helpful. I mean, if you take, I'm sure that all other MPs have had this, that you meet the proprietors of the care homes and the domiciliary services, and there's been recently an increase in the minimum wage, and they will tell you quite bluntly, without any shame, that is going to be a challenge for them. That is the biggest problem that they currently face in terms of maintaining the viability of their business. So there's a strong resistance there amongst them to increase wages, and if one, of course, they don't care two hoots, and I'm not saying they don't care, but I'm just saying they would, in terms of their viability, they wouldn't be impressed by being told, yes, but it'll cut the universal credit budget for the government, because that's obviously not of their concern. So how do we get the health economics to work in a more virtuous way, so that we can improve the wages of care workers, and justify that in, if you like, a wider sense, so that we're not putting these important businesses, kind of out of business, and actually making a strong case for an upward spiral to kind of pull people, into better kind of careers and career structures.
Yeah, I think this is where really having a hard look at reforming the way we commission and contract is really quite important, because so if we can move to a system that either buys outcomes or capacity with more certainty of income, then actually you've transferred some of the risk away from the provider, and so alongside hourly pay, the 0 hours contracts and the guarantees of hours matters. So there's some issues there. There are also issues, I think, and questions to ask about. At the moment, there's quite an interesting difference. In the NHS, providers are not allowed to compete on price. You have to compete on quality. We have it all got mucked up with the COVID. But theoretically, pre-COVID, we had a system where you set a tariff, a fair rate for job nationally. You adjust it for different costs in different parts of the country. But a hip replacement, there's a price nationally. And then you adjust it for local differences. So you can't have a race to the bottom on price. You have to compete on quality. In social care, we have people pushed to compete on price. And price, all the evidence is now that the rates we pay are below the cost of delivering decent quality of care with decent terms and conditions. I think there is a question about whether or not we should look at whether or not we need to make competition on quality rather than competition on price. It would also make transparent then what extra burdens are being passed to local government when you have decisions made in other parts of central government about social care, because kind of everyone passes the buck and it's so opaque that it's very difficult at the moment really to understand. And
are you suggesting copying the model over, for example?
Well, I mean, you wouldn't directly copy it, but essentially the basic idea would be that you set tariffs. I would argue you could set tariffs as well for outcomes or programmes of care, so that, again, you get away from the task and essentially you allow people to compete on quality. That's the model, the basic principles that we have in healthcare, and they're quite important principles in services where quality is so important, difficult to observe, and the tendency therefore is to compete on what you can see.
That's really, really helpful. Just finally, just the disaggregation between a residential care and domiciliary. Just what has happened in view of what you've just described? I mean, what has happened in respect of the care workers, if you like, conditions of employment with regard to travel time and travel recompense and having sufficient time to care when they get to the home? This has always been a contentious issue in the past. I mean, how has those issues been properly addressed, and can they be addressed in the fair pay agreement negotiations?
I mean, I would say that the fair pay agreement is the opportunity for us to have the conversation around pay, and it's really, really important that we all engage with that. We will have some choices to make. Providers have been very clear that for the fair pay agreement, we've got to look at funding. We've got some choices to make in terms of what the policy intention is, and the Low Pay Commission estimate that about 15% of care workers are paid below the national living wage because things like travel time aren't taken into to account. So even just enforcing the national living wage would have an impact, the Low Pay Commission would say, on about 15%.
I mean, what proportion of providers are not covering the travel time? Do you know? Is there any figures on that?
No, other than that Low Pay Commission figure. We can see a difference in some other terms and conditions, like 0 hours contracts, which are much more common in home care than in residential care because of the model, because of how it's commissioned, and so around 47% or so of the workforce in home care is on a 0 hours contract. And so we can see an impact on of some of that, and some of that is because we're trying to balance people's real desires to have care and support that's tailored around their needs. So a lot of people want to be supported in the mornings before 8 o'clock, for example, and then there's a time during the day that fewer people want to be supported. So trying to get that balance between the commissioning model, the workforce, and people's needs. I think that's the conversation that we need to have.
Thank you. And Danny Bills.
Thank you. I'm going to ask a few questions about kind of measuring the costs, if that's okay. Some data around, including data, and following on from one of my colleagues' questions as well. I just wanted to come back on something, Oonagh, you raised in the previous answers to the committee. You talked about having modelled the impacts of different pay levels, and kind of following on from Anita's point earlier about the kind of indirect costs to the Treasury of low pay in the sector. So did your modelling also include impacts on Treasury in terms of benefits, you see entitlements reducing, other social entitlements reducing with increasing pay, or was it just kind of direct modelling of the impact of the pay on the sector?
Let me send a note to the committee. I don't want to say something and then I have to say that I was wrong. So let me send a note to the committee on the detail. On
that point, I wanted to ask Anita. So are you aware of any evidence that kind of models the cost to the Treasury of low pay and poor conditions in the social care sector?
Yeah, we do have some figures, and I'm going to find it, on the number of people on universal, proportion of the workforce with universal credit. And again, if I can't find it quickly, I know we've got some data around that, maybe and I can send that really through help. As well. Yeah,
it's quite, as you say, quite key data, and risk robbing Peter to pay Paul. We think we're making a savings to Treasury, but ultimately Treasury is paying. Yeah.
So let me send you a follow-up note on that one.
That would be helpful. And I was also interested, Anita, in your point about regional economic development, and if you had any further evidence around potentially the regenerative benefits to the Treasury of the growth in the sector, growth in the quality of pay and conditions in the sector, and what that might mean for regional and local economies.
There is a study in the West Midlands, which was done by the New Economics Foundation, which looked at that regional impact on social care. And if I send you a note with Universal Credit, I can also send you the link to that work, which is very relevant to that. Yeah. And I'll have a look. Have you got regional breakdowns in your data?
Yeah, we do. And the economic report that I'll send to the committee showed that in some regions, like the Midlands, for example, social care makes up a higher proportion of the workforce and a higher proportion of the economy then. So we model some of that out regionally.
Really helpful, thank you. And just lastly, Oonagh, I think in one of the first things you said to committee, which was quite stark, was some quite clear evidence on the benefits to the economy of social care around indirect and induced kind of values. I wanted to understand a bit more. Do you have any sense of relatively how that compares to other sectors? So if from a Treasury perspective, you were looking at where you invest, if we had a sense, well, if they invest in childcare, there'll be a greater or less or equal indirect or induced benefit in terms of employee spend or the other costs you talked about.
So this is the point that I was making around, I think as a sector we can do more to support DHSC, MHCLG to make to help people understand more about social care, both in terms of what it delivers for people's lives, but also in terms of workforce. A lot of people don't know that social care employs more people in the NHS, more people in construction, more people in transport, more people than food and drink, and there is a story, I think, to be told that we need to help in the telling, and just given the scale of that workforce, comparatively speaking, the scale of impact on the economy is obviously really significant.
Can I add just a couple of things to think through in that? And I think it's a really good question, and I don't have the direct answer to it. But one of the things that people talk about, which is quite important in the everyday economy, is that if you put any more money into someone who's working in the everyday economy, then they're by and large low paid. They will spend all of that locally, significantly locally. The other thing that's quite important to think through is in these sectors where the state has such an influence on pay, there's that direct observed effect of low pay through being on universal credit, but also, many of the families where someone is working in social care, they will have their children are the children who are the child poverty statistics, which other parts of government then are trying to think about how we deal with. So the sort of consequences of low pay are quite important, obviously, both overall, but also then where you do have parts of the country where it's a much bigger share of the workforce. We know that concentration really matters, and having large numbers of people in low-paid work with children in poverty and insecure work is a real problem for those communities.
Thank you. Some of the witnesses in our earlier sessions talked about the benefits of social care reform on other public sectors in the economy. So policing, housing was talked about, as well as the discharge issue and the health service more broadly. Is there any way outside of social care you think we should be particularly looking for possible benefits of social care reform?
Can I make one point? So when we look at in the workforce strategy, one of the things that we suggested was that we need to be focusing more on getting more younger people into social care. We're underrepresented in terms of our younger generation, and also men. We're underrepresented in terms of the number of men in social care. There is a real opportunity, given that this is a sector that is going to need to grow, and we can't say that about all roles. 540,000 additional posts by 2040. There is an opportunity for us to appeal to a new generation of people who wouldn't necessarily think about social care, who might have been out of work, who might be long-term unemployed, who might be leaving one sector for another. There is an opportunity in a sector that can give you real purpose. We hear from younger people, particularly, that when they're coming into the labour market, well, I want a job that gives me flexibility and gives me purpose. I can give you that in bucket loads in social care. We also need to make sure that they're good quality roles. Interestingly, although we do have high turnover in social care, we have lower turnover than similarly lower paid roles, because when people get into social care, they get so much from it. So I think there is a real opportunity when we're thinking about getting people into work, getting people back to work, to make a real case for social care as that potential. Even if people don't stay forever, don't build their whole lives in social care, the skills that you learn, and you can come into social care without any qualifications, and we will train you up, and you will learn some really amazing transferable skills. And I think there's a real opportunity there when we're looking at getting people into the labour market.
I just wanted to add to that, actually, in terms of public services, where does this have a positive impact? Pensions, people's ability to build up pensions over time. And the other one, which I said before, was 1 in 3 of the NHS workers are unpaid carers. So with all of the labour market issues we were talking about there, you can apply that as well to the social care sector. We don't know the exact proportion. Very old studies suggested it was about similar. So I think you could probably add that to your list as well.
And are there studies that sort of back that up, or we're just looking at sort of general broad? I mean, we really do want to try and drill down into actual numbers if they exist.
Yes, so the Pensions Policy Institute looked at unpaid carers as being underpensioned, and a disparity between the two. And then the Social Care Workforce Survey, I think, had an identifier question to see whether people were unpaid carers as well. You could ask the Department for Health and Social Care for those data if they've got it. They might not have that analysis, I don't know.
I think there's another point which is possibly less around public services, but more about kind of equalities agenda. Social care is an equalities issue. There's a real equalities lens there, because we support two of the groups in society that are likely to be most discriminated against, older people and working age adults, and we are employed disproportionately by our staff made up of disproportionately female and people from ethnic minorities, and so there is a real potential in social care to be a really diverse sector, to kind of fly the flag for this is the most inclusive and the most diverse sector that you can work in. We also need to make sure that it is inclusive, but I think there is another lens in terms of equalities and equity as well that's really, really important.
Thank you. I mean, did you want to come in on this, Andrew?
No.
Thank you. I mean, as the kind of questions are getting to, kind of evidencing and demonstrating data around some of these issues has been a challenge. I think it's what when in the cold light of day, kind of Treasury colleagues are making these kind of somewhat harsh decisions about investment. It can be a barrier. I understand that kind of client level data it has been rolled out. There's kind of a hope that data in the sector is and has improved. I wanted to get your sense of the impact of that, what additional insights that's that's given you and impacts, I suppose, on addressing some of these questions, and where you think there might still be limitations in data collection.
Shall I start?
Yeah.
I think we'll all have a view on that. The workforce data that we use comes from the Adult Social Care Workforce Data Set, which covers 650,000 staff working in social care. It's commissioned by DHSC, and it really helps us understand the care provider and workforce issues, pay, vacancy rates, sickness. We're really lucky in that that's really high quality data, and we've had it for more than a decade, so we can see the trends as well as the kind of immediate impacts. And it's the ability to combine that with local intelligence so that we can properly analyse and understand what that's telling us. When I was thinking about the question in terms of gaps, we do the projection based on the growth in the workforce, so that figure of 540,000 additional roles that we're going to need in social care by 2040. But that's just based on the ageing population. What we don't have is the equivalent for working age adults. So that modelling could be much better if we knew what we were expecting in terms of children being supported now coming into social care, and that combined with really good national system level and local workforce planning would be incredibly helpful, not just so that we can plan for the numbers in the labour market, but our needs are changing. So by 2040, we're expecting to see a 43% increase in the number of people with dementia. The support that we need, the training that the workforce needs, the skills that we need are going to be very different. And that was one of the recommendations from the sector in the workforce strategy, that we had a statutory requirement to do workforce planning so that we could do that at a system level and then at a local level. It would also be really helpful to see where people go when they leave adult social care, and that's something for us to think about. People moving between NHS and adult social care, so the Health Foundation research is really helpful. Is there a way that we can track that movement, linking workforce data with client data, so that we can get a sense of the impact of funding source on workforce, and see whether that makes an impact.
Sorry, is that possible now with client level data, or does there need to be evolutions and additional data collection to enable that?
I think it's possible, but it's not happening currently. And then the only other thing that I would say is that we are adding questions to our data set to better understand how many people are performing delegated healthcare tasks, because that's an increasing policy area between health and social care. We are hoping to be able to look at what those tasks are, pay, training, qualifications, because we know that care workers are doing more and more delegated healthcare tasks, so just getting a better understanding of that should help with the data as well.
Anita, do you two things, three things actually that I think are really important. So one is that we have a better understanding of the self-pay market alongside the publicly funded provision. So there's been a lot of studies trying to understand what reduced public support has meant in terms of, say, use of NHS. But unless you can understand, well, is it that then someone got no care, or they had to have some different care and it was privately funded, it's really difficult, and the research is very limited then. So if we want to understand, if you're the Treasury, from a public policy point of view, where do we best put our funding? You need to understand the whole picture and the consequences of reduced funding in some areas. Linked to that, the other thing that's very difficult is we often have information on the workforce, or we have information on the people. Linking those two is really, really important. And the other bit we want is, what's the model of care? Because a lot of what we want to understand, and a lot of your questions, really good questions, are how can we do this differently so that we get better outcomes, better value for money? And for that we need to understand, well, what is the model of care? who did it work for, who didn't it work for, what consequences did it have. So that's really important. And all of this, the final point I'd make is, I mean, it's great to know about a point in time, and if you're delivering a service, you need to know now. But if you're doing policy and planning, you need to be able to follow things over time, because often, and the wonderful Sure Start is a great example of this, isn't it? Yeah, it was only by being able to actually do a long-term evaluation that we were able really to understand those effects. And with something like social care, where some people will not use it for very long, but many people will need care and support very long term. And understanding the dynamics of that is really, really important to inform policy. So we need to be able to follow people over time.
Helpful, thank you.
I have one more bit to add, if you don't mind. In terms of data, I think local authorities kind of had their hands slightly tied, because there aren't very many local data sources that you can use to look at unpaid carers and their journeys. I don't know if you would agree with that, with your experience, but so we have the census, other national data sets. The GP patient survey is very important. We don't have formal measures of carers' experiences of hospital discharge, not talking about the patient's experience, but talking about their own experience. How was it for you? Did you get the right support? And when you decouple those questions, you get different answers. So, and I think these data linkages are all really, really important. I'm interested to see a smaller number of questions on client-level data for unpaid carers, but I'm interested to see what happens in the 10-year plan, and where might local authorities be able to improve their administrative data look. All you need is an identifier question. Are you also an unpaid carer? Yeah. And then you can, if you have the right permissions, but you can start to link data sets.
The countdown has begun. Last question, perhaps.
Fantastic. So we may have up to 3 years until the KC Commission completes its work. Kind of advising, I suppose, Baroness Casey and the government now, what studies and research should the government commission to help inform and build an evidence base for reform? Are there particular things that you think are vital now to commission to inform that?
Each get up to 2.
Right.
Yeah. Who wants to start?
So I would first make the point that even within those 3 years, there are things that will be happening that will have an impact, particularly on workforce, like the Fair Pay Agreement, like the Employment Rights Bill. And so it's not nothing between now and then. There will be quite a lot that will impact on the workforce. I would say the two things that we could do with knowing a little bit more about is having more of a focus on retention. We often have a focus on attraction. I'm really keen that we keep focusing on how we're keeping the people with really good values and really good skills that we need in the sector. And there's a big piece around skills in social care and training. We've seen a 75% reduction in the number of apprenticeships in social care since 2016. And so how the new skills reforms and skills agenda really works for social care is going to be really important. And that will happen much more immediately. That's happening now in terms of the policy thinking.
I would look at the economic impact of social care, taking perspectives, labour market, employers, carers' own perspectives, young carers, of course, people coming in with educational opportunities, and I would look closer into the link between positive social care and carers' health and well-being. Commission those. The economic impact would also have a link to poverty prevention. Kind of boiling the ocean with that one, but
because I think this needs to be really about the future. I'd like to see her commission or do some work on the productivity potential of the sector going forward, and I'd also like to see some really good subnational analysis. Because I think that is really important. Social care is locally provided and it's local labour markets, and I think if you just do come at this through a national lens, you could find that things don't work in areas, or so I would do those two. And everything that else has been said.
Absolutely. And there's something about in the meantime, we will all be getting on with, so the workforce strategy as an example, we'll be getting on with implementing that and making the change that we can make in our own spaces, because that's really important.
Perfectly timed. Thank you very much, all three. That brings us to the end of our session. Order, order.